In our lectures today, we will review the behavioral and psychological symptoms of dementia. As we said before, that dementia is considered one out of one's mind, okay, where it is defined as a disease with acquired deterioration in cognitive with intellectual abilities without impairment to conscious level, okay. And also we mentioned that there are many causes of dementia. Some of them are reversible, others are irreversible. The irreversible as Alzheimer's disease, which consider about approximately 70%, the vascular dementia, the Parkinsonian dementia, frontotemporal, normal pressure hydrocephalus, dementia with Lewy bodies, delirium and depression, and less other common causes which will not be discussed. Actually, there are many stages of dementia that affected person or elderly will pass through. In mild stage, or mild cases, from it takes about 2 to 4 years. Okay, in early demented person, there will be loss of memory. The language will be affected, so that due to affection of the semantic memory, there will be mood swinging, personality changes, diminished judgment, or apathy. And apathy, sorry. In moderate cases, from 2 to 12 years, okay, it takes about 2 to 12 years, there will be an inability to retain new information. This is due to affection of the short-term memory, okay. There will be also some psychological impact and abnormality in the behavior. There will be personality changes, agitation, wandering, aggression. There will be increasing in the long-term memory, affection here, okay, confusion, and in this case, some elderly will require assessment. If we pass to the long, severe cases, which takes up to years, okay, which differ from one person to another according to the degree of brain damage, okay, and neuronal affection, there will be a gait and motor disturbance, and maybe the elderly patient be bedridden and restricted to the bed with no activity at all, either activity of the daily living or instrumental activity. Okay, he will be fully dependent on others, incontinent, show some psychological abnormalities or changes in the behavior, in the personality, increasing in the agitation, and so on. And in these cases, usually elderly requires a long-term care, placement, and caring from a professional persons in nursing home or long-term care centers, because lacking of the experience of the caregiver how to deal with such a patient. Usually the neurotransmitter which is related to the development of dementia is acetylcholine, the dopamine, the norepinephrine, serotonin, glutamate, and gamma aminobutyric acid. We have discussed before on the cognitive function and dementia in the elderly on the previous lecture. As we say, that will be cognitive decline on different type of dementia, and it's one of the criteria of diagnosis. There will be behavioral symptoms, which is usually identified on the basis of observation. There will be swinging and alteration on the personality of the person, his relative and the caregiver or the one who is near to the patient will observe it early, okay. This will include the physical aggression, the screaming, the restlessness, agitation, wandering, culturally inappropriate behavior, hardening and sexual disinhibition, cursing and shadowing, okay. All these will be in some cases such behavioral changes may be accompanied and very obvious, okay, and may become a problem, especially socially, okay, for such a patient, especially when they are elderly have a respectful image and must be have a certain way of behavior and acting. So such acting in proper way will be a problem, a serious problem for the patient and his relatives. Actually, the range of behavioral changes that may accompany the dementia, okay, in addition to the cognitive and memory impact, okay, there may be personality changes as that may range from psychosis, delusion or hallucination, agitation and aggression, apathy, indifference, depression, dysphoria, anxiety or disinhibition, irritability, insomnia, appetite disturbance, apparent motor behavior. All these factors may be very prominent and obvious in the patient, accompanying the memory impairment, and all this will interfere with his activity of daily living, the judgment, the problem solving, and so it will have its impact on his daily life. And may lead in depression and suicide attempt in late stage, or neglect his personal cleanliness or personal hygiene, which increase the incidence of infection and so on. So that every symptoms may of this may lead us to a serious complication that accompany. Actually, there may be subtypes of these behavioral and personality disorders, okay, that accompany dementia, as Mansfield mentioned. There will be physical aggressive behavior as hitting, kicking, beating, or non-aggressive as pacing, inappropriate touching, maybe in other way, maybe verbal aggressive or verbal non-aggressive. The verbal aggressive behavior are cursing, screaming, keeping, telling inappropriate words or something like that. And the verbal non-aggressive as repetitive of the phrases or aggregate and calling out, keep calling out for nothing. He is actually not need anything or any help, but he is keep calling the surrounding as a kind of paying attention or seeking for attention from the surrounding. This image actually summarizes the behavioral changes, okay, either physical aggressive or non-aggressive, and verbal aggressive or non-aggressive attitudes, okay, that may occurring and accompanying the dementia or memory impairment, okay. And now we will talk about and differentiate of different types of dementia and the brain associated changes and pathological change may occurring, also the behavioral and emotional psychological changes that may occurring with different types. We are focusing about this psychological aspect in depth. Now we will discuss the different types of dementia as a psychological impact or association with these types, okay, and the behavioral changes that usually accompany different types. Let's start by the frontotemporal dementia, which is also called the Bpsd disease. It's caused by shrinking of the frontal and the frontal lobe of the temporal lobes of the brain. The name tells its dementia involves, as we said, the frontal and temporal, so that's why it's called the frontotemporal dementia. As we know that the frontal is responsible for the regulation of the personal behavior and maturity, okay, and critical thinking skill. It's the one which tell us to stop and to act in a certain way and to act in a proper manner way. Okay. Meanwhile, the temporal lobe includes the language center of the brain, which allows people to communicate with each other and allows the elderly to express themselves, use language, use words in a proper way. As we said, that Bpsd disease or the frontotemporal dementia is present with impairment on the recent memory or short-term memory, also with interrupting cortex and hippocampal affection. The Bpsd diseases typically affect the frontal and the anterolateral part of the temporal lobe. Okay, there will be associated behavioral changes to psychological and the emotional, behavioral. There will be mutism, there will be aphasia, echolalia, which is repetition of whatever spoken to them. He will keep repeating the last word the clinician or someone around is saying. He will keep repeating the last word he is hearing. There will be rigidity, apraxia, weakness, memory loss. That means there will be motor affection for a certain degree. The brain changes that accompany this condition is that there will be severe atrophy, neuronal loss, and gliosis. There will be accumulation of tau positive inclusions, okay, or neurofibrillary tangles, which is very characteristic in dementia. There will be swollen ballooned neurons, which is called the big cell. And from here, this disease got its name. There will be argentophilic neuronal inclusion, also known as Bpsd. So here we have the Bix cells and included in them the Bix bodies. Okay. This will affect the frontal and temporal cortical region. Few Bix bodies may be present in this if the primary symptoms are behavioral, okay, compared with the primary symptoms of aphasia. So that means that if the inclusion of such Bix bodies and its included the Bix cells and its included bodies are more in the frontal symptoms will be dominating or more characteristics or featured than if the temporal lobe is not affected to the same extent. Dementia may be caused by infections. Also, it's a type of dementia, the Creutzfeldt-Jakob disease, the human immune deficiency viral infection, viral encephalitis, or progressive multifocal leukoencephalopathy. In Creutzfeldt-Jakob disease is a rare degenerative fetal brain disorder. Okay, it usually may affect about one person in every 1 million per year worldwide. Okay. It's usually occurring on the later life, okay, and runs a very rapid course. Usually, the fatality is about 1 year since the onset of symptoms, okay. In the early stage of the diseases, people may have failing memory, behavioral changes, lack of coordination, visual disturbance as the illness progresses. Also, there become these mental changes are pronounced and may be associated with involuntary movement, may end in coma, okay, and in the later stage is death. In Creutzfeldt-Jakob disease, there is abnormal protein found in the brain called proin, which is this proin in its natural forms, okay, is harmless. It can be made by most body cells and doesn't cause any diseases. But if there is mutation or abnormal form of these proins are formed, there will be toxic to the brain cells, which causing disease and damage to the brain. One kind of damage is spongiform changes, in which the brain tissue looks like a sponge, and there will be tiny holes, okay, and many of the brain nerve cells die, leading to symptoms like dementia. One type of the dementia is the cortical dementia, where the brain damage primarily affects the brain cortex or the outer layer. Cortical dementia tends to cause problems with memory, language, thinking, and social behavior. It's actually the frontotemporal and other part which is affecting the cortex. In the subcortical dementia, it will affect parts of the brain but below the cortex, okay? This will cause some changes in the emotional and movement, in addition to problems with memory, okay, which is one of the characters or the criteria in the diagnosis of dementia. Otherwise, in progressive dementia, which gets worse over time, gradually interfering with one or more of the cognitive abilities of the person. In cerebrovascular dementia, which is known previously as the multi-infarction or post-stroke dementia, which is considered about 20% of all cases, is very common, usually in elderly after stroke, and usually if associated with many comorbidities as diabetes, hypertension, and so on. Okay. In multi-infarct dementia, which is atherosclerotic or subcortical vascular dementia, there is impairment on the judgment or ability to plan steps needed to complete a task. Okay, this is due to affection of the frontal on the is more likely to be associated with initial symptoms of Alzheimer. Okay, this is due to actually due to the brain injuries is microscopic bleeding and blood vessels blockage. Okay, either by thrombosis or embolization. The location of the brain injury is determined how the individual will be the outcome after the resolution of the causes of the blockage or hemorrhage. Okay, this will determine how the degree of affection and the degree of dementia and its stage. Okay, it may affect the individual thinking or physical functioning will be affected. If it affects only the sensory or the motor area will be also affected in such a condition after strokes or intracranial hemorrhage. The brain changes can often affect the blood vessel problems implicated in vascular dementia. Another form of dementia is the neurodegenerative dementia like Bpsd disease, Huntington's chorea, or Parkinsonian disease. As Parkinsonian disease progresses, it will result in dementia similar to that with dementia with Lewy bodies. Okay. Actually, the symptoms here will be the motor affection will be the most prominent symptoms, okay, in early stages, and the Parkinsonian disease is characterized by spasticity and motor affection to great extent, okay. If dementia develops symptoms, it will be similar to that of dementia with Lewy bodies, okay. There will be resting tremors, a kinetic rigidity, hypomania. Okay, the brain changes are usually in the form of alpha-synuclein. Alpha-synuclein clumps are likely to begin in an area deep in the brain called the substantia nigra. Okay, these clumps are thought to cause degeneration of the nerve cell that produce dopamine, which is actually controlling the motor activity and causes its pressure. There will be rigidity and spasticity, which is very characteristic for the Parkinsonian disease. There will be also the normal pressure hydrocephalus, the nutritional dementia, okay, which is due to deficiency in vitamin B12 or folic acid deficiency. Okay, as we know that B12 and folic acid are very important for the nervous system and the neuronal activity. Okay. There will be difficult. The symptoms will be accompanied is the memory problems. Okay, that's why we consider it part of the dementia. There will be difficulty in thinking and social skills. Okay. But to some extent it will seem to be not much that affected on this condition in the nutritional dementia, okay, as in other types. Okay, actually the brain changes that will occur is that thiamine, as we know that it helps the brain cell to produce energy from the sugar. Okay, actually when thiamine level fall too low, The brain cannot generate enough energy to function properly, okay, so that it will affect the transmission of neurotransmitters, the vitality of the neurons, the activity, the metabolism. All these integrate together and have its impact on the capacity and the capability of the neuron to act normally. Other metabolic disorder or disease that may affect not only the nutritional but the metabolic disorders as the parathyroid, the Cushing, the thyroid, the hepatic, okay, the chronic inflammatory condition, the trauma to head injury, which may affect the brain, as in boxers and alcoholic, okay, this by repeated cerebral concussion and the repeated accumulation of blood and fibrosis will affect the brain cells either by pressure on it or by impact the vascularity and the renewal ability. Okay, this will later on cause weakness in the lower limb, unsteadiness, slowness of the muscular movement, hand tremors, hesitancy, and mental dullness or memory impairment. Okay. Tumors may also causes dementia as the top frontal meningioma. It may rarely occurring dementia may rarely occurring due to intracranial tumor, especially when tumors in certain anatomical sites, okay, and affect special sites that is related and functioning in the memory process. There will be mental or behavioral changes, okay, as in frontal lobe tumors or ventricular tumors and corpusculosum tumor. There will be cognitive impairment and memory affection are known to be and reported in such cases with in such tumors, okay, as a non-metastatic complication of systemic malignancy. Okay, it is part of the tumor process and not due to metastatic affection of these areas. To evaluate such patients, we usually do the comprehensive geriatric assessment and complete evaluation of the patient. We took the history either from the patient himself, if in early stages, and the cognitive and memory is intact for a while, okay, or the relative if there is complete or in late stages of dementia. We must report the rate of intellectual decline, the impairment in social function and activity of daily living, the general health and the relevant disorders, the nutritional, the drug history, the family history. Okay, then we do scaling and evaluating the cognitive ability by the memory, the abstract thoughts scales, the judgment scale, and the higher cortical function scales. Okay. In early pseudodementia, a formal assessment from a clinical psychologist is advisable and preferred to ensure that such condition is not related to psychological problems, depression, and so on. After that, we do the physical examinations, the involuntary movements, the pseudobulbar signs, the primitive reflexes, okay, the grasp reflexes, glabellar reflex, and the mental reflex, okay. All this evaluation neurologically and psychologically and other cognitive skill must be done to evaluate the degree of dementia. In the dementia, there is some skills we use usually as the mini-mental, the slums, the frontotemporal scales or battery. All these are usually used to evaluate the degree of dementia or if there is actual cognitive or memory decline or not. Other diagnostic approach must be done actually at the magnetic resonance image, the CT scan, the SPECT, the PECT, okay, the PET. All this will help in evaluation if there is a target area on the brain or neuronal loss, there is any neurological lesions affecting the brain. All these help us to evaluate the cause and the prognosis of the dementia. The lab studies CPC, the erythrocytes, the thyroid functions, and for nutritional dementia, we evaluate the vitamin B, metabolic as liver function, blood sugar, toxicology screening, electrolyte tests, the anti-nuclear antibodies, okay, the lumbar puncture. All these may help us to evaluate. And later on the confirmation is done by autopsy or biopsy. This is after this actually, which help us on doing more studies and understanding dementia more and more with time. Actually, we must differentiate the dementia and the delirium and depression from each other, okay, because they are closely related, and some physicians, especially if not pediatrician, may misdiagnose them and differentiate them from each other. Okay, in dementia, as we know that and find it, it's a chronic loss of intellectual and cognitive function. Okay, severe enough to interfere with the activity of daily living and may be associated with behavioral changes. But in delirium, it is acute disturbance of consciousness marked by an attentional deficiency and a change for cognitive function, hallucination, autonomic overreactivity as a consequence of toxic metabolic or infective condition, which is the causes of delirium. So that the main item that differentiate delirium from dementia is that dementia is chronic. This is while delirium is acute, and in dementia no loss or disturbance on the conscious level, but in delirium it is main symptoms or main presentation will be the disturbance of the conscious level and attention. Okay, while depression is the affective disorders, even evidenced by a dysphoric mood, but the most perceived symptoms is the loss of ability to enjoy usual activity. These syndromes are not mutually exclusive, as dementia frequently coexist with delirium or depression. So that's why we sometimes not distinguish one of them from each others and misdiagnosed them. Actually, can prevent dementia or postpone the appearance of its symptoms, okay, by people who have dementia due to stroke and able to prevent the future declines by reducing the risk of heart diseases. Okay, there is also must keep the mental exercises, a healthy diet, stress management. Okay, as part of the dementia is usually related to the stress and wear and tears of the neurons. Okay, the active social life and involvement in activity and be psychologically well-being. Okay, all these factors integrate together to help the healthy brain. Also, the balance and fitness and physical exercise is playing a very important role for preventing atherosclerosis, overweight, obesity, diabetes, all these comorbidities which may have its impact on the neuronal function and the nervous system of the individual. Actually, medications may help to maintain the mental function and to postpone the deterioration with the mental abilities, okay, that accompany dementia, and may prolong the stages, okay, so that we will not jump from one stage to another that early, and may delay the neuronal affection to some extent. As the cholinesterase inhibitors, okay, as donazepam, the Aricept, the Rimaneal, Exelon, sorry, the memantine, okay, which is used to treat Alzheimer, and also it help in vascular dementia mainly, okay, but actually we not know clearly how long this medication work effectively, okay, because it needs researches on brain autopsy and not can be evaluated during lifespan of the individuals. Also, as we said, there is the behavioral and mood affection that's usually accompanying the dementia and behavioral changes. There is a great need for medications that control the mood and behavior, the antipsychotic and the antidepressant. That's used usually, but better when applying the antidepressant as SSRI, okay, from the changes that may accompany its administration, especially on the heart, okay, as the affection the affection, okay, on some waves, okay, on the QRS and so on, that accompany the administration. Actually, as we said, before, that the dementia is accompanied by mood and behavioral changes, and it's usually a great problem. So that we may administrate some medication to help control the mood and behavior. The antipsychotic drugs as risperidone, okay, and olanzapine, dyspraxia. Also antidepressant, usually we prefer the selective serotonin uptake inhibitors, but we must take care during the administration of such medication by follow-up of the heart, okay, because we know that such medication may cause some changes on the waves of the heart, okay, especially the QRS may cause its prolongation more than 120 milliseconds, okay, due to administration of such antidepressant. So that professional and keep caring and near observation of the patient is advised when administering such medication, okay. And medicine to prevent future strokes, okay, especially in high susceptible patients, okay, by controlling the blood pressure or the cholesterol, or the administration of anticoagulant medication. Also, changing what you eat and may reduce the dementia symptoms by improving, because as we say that there is nutritional dementia, so we must correct the nutritional state and intake of the proper vitamins that the body needs. So now we can summarize the behavioral and personality disorders accompanying dementia in the form of clusters, as agitation may be in the form of pacing or repetitive actions, dressing or undressing in a proper way, restlessness, anxious. The aggression may be in the form of physical aggression or verbal, or aggressive resistance to care, okay. The apathy as withdrawn and from social activities, the lack of interest, the unmotivation, the depression in the form of will be present in the form of sadness, tearfulness, hopelessness, guilty feeling, anxious, irritable, and suicidal attempt in many cases, may be in the form of mania, euphoria, pressure, speech irritability, psychosis in some cases as hallucination, delusion, misidentifications, and suspicions. All these behavioral changes may be one of the component or criteria of diagnosis of the dementia, okay, and usually accompany the different types of dementia. Actually, we need to differentiate dementia from pseudo-dementia, as dementia has insidious onset about years, okay, and there is history of psychiatric problems are more common in pseudo-dementia, okay. This is a kind of differentiation. Also, in dementia, there is mild complaints about memory and concern, Okay, but in the depressive pseudo dementia, he is always complaining all the time. So, okay, in dementia there is behavior in line with the clinical severity, but in depressions there is incongruence between behavior and severity of cognitive deficiency. Because in depression, that means the complaint is depression and usually due to psychological problem. Actually, all these associated emotional and psychological or behavioral changes that accompany dementia, in addition that dementia is by itself is a serious problem because it has its impact on the memory, the giving the judgment, the ability of proper judgment, problem solving, thinking, and so on, doing activity of daily living and becoming independent. The overlapping behavioral changes and psychological impacts that accompany dementia may be a burden over the caregiver, okay, and the surrounding who is looking after this elderly person. This may expose the caregiver to stress, increase the ER visits, the emergency. Okay, also as we mentioned, there may be complication from the medication and the anti-psychological medication the elderly are taken. There will be a prolonged hospital stay, bedridden, and its complication from deconditioning, weakness, pressure ulcers, and so on. There will be increased use of medication, which may be burden financially and also psychologically, or may on the physical condition of the patient. Okay, there may be increased financial cost and prolonged restriction or placing on the long-term care, which is also burden on financial on the caregiver or the families of this elderly population. Maybe a financial problem for the elderly himself, who is become dependent only on the retirement money, okay, which is very small budget, okay, so he cannot pay for the medication for the long term for the caregivers. Okay, all this integrate together to decrease the quality of life of the patient and his surrounding, either his relatives or the caregiver or whoever looking after him. At the end of the lecture, I would like to thank you for your attention and concern, and wish that everything was that clear and be helpful for you.